this. Dr. Ciro?
Okay. All right, well, thank you all for coming. I want to just start by kind of talking a little bit about what we do know at this point. So for those of you who aren't aware, that about 5.5 million people in the United States and about 75,000 people in Oklahoma have been diagnosed with Alzheimer's disease and or related dementias. All of those people, and I'll emphasize, all of those people will eventually report some change in their ability to perform either basic daily tasks like bathing, dressing, eating, or more advanced tasks like cooking, cleaning, managing your own finances. Surprisingly, despite the number of people that are going to have this kind of change, we have no standard interventions for how to either delay the progression of loss of those abilities or to improve those abilities in the people that are currently losing those. So at the Health Sciences Center, we decided to put together a research project where we could help patients and families think about how to maintain those functional skills. And the intervention we came up with was an intervention by the name of STOMP. So it's kind of an easy to remember name, which stands for Skill Building Through Task-Oriented Motor Practice, which is a kind of a long string of words, which basically means we're going to repetitively practice the tasks that people report that they're no longer able to do. So for example, if somebody says, I'm having difficulty managing my own medications, the STOMP intervention team will watch them try to manage their medications, which might include things like put them in pill dividers or remember to take them at the right time. So we'll watch them through that process. We'll figure out where are they having their issues, where are the errors occurring. From there, we will then come up with strategies to make it easier for them to perform, or it might be that we introduce some type of technology that will make it easier for them to perform. So for example, the study might actually purchase an electronic medication reminder system for that person. So at that point, we know what their issue is, we have technologies or strategies to help them, and now we're going to repetitively practice that task using those new strategies and that technology. What we hope we gain from that is that by this repetition, that we're actually hardwiring the brain to perform this correctly. Now, this is a very time-intensive study. We're doing a two-week time period, 3 hours a day, 5 days a week. We chose this model because it's been successful with other people that have other types of neurological conditions like stroke. So people will need to be able to come to the Health Sciences Center for that time period. We do have some assistance for helping folks with transportation costs. Other things that we look to see that folks are eligible for this study will include that they are living at home, and a home could be assisted living. They do need to live with someone, whether that's a spouse, caregiver, daughter, family member, somebody who can help carry through with the techniques we practice in the lab, in the home. They need to be able to read and understand English so that we can appropriately communicate with them. They need to be able to follow a basic one-step command like stand up, sit down, raise your hand. They also need to be able to participate in that type of intensive therapy for 3 hours a day, which can kind of be a long time period. Of course, there'll be breaks inserted, but they need to be able to not have medication schedules or physician or rehab schedules that would prevent them from doing 3 hours a day. So people that are interested in more information can look to our website, which is on the College of Allied Health, or they can contact me personally by phone or by email.
Sure.
Good afternoon.
You had a chance to look at the lab and kind of see the setup for this study. Tell me what you think about that and how that might help others.
Well, first of all, the lab environment is very realistic to a normal home setting. Now, it may not be set up just exactly like your personal house, but it's very much a normal home set. And so in light of what they're trying to accomplish in this, of helping people stay at home longer, I think the lab is very conducive of being able to be used as a training ground for such.
Right. When were you diagnosed?
October of 2007.
And that was with early onset
Yes, ma'am.
Alzheimer's?
Yes.
What were you must have just been surprised and shocked, and, tell me what was going through your mind and what's happened since then, what you think ahead?
Well, what I felt at that time was a lot worse than shock. It was basically the worst thing, other than hearing something about my children or my wife. You couldn't have told me anything that would have affected me any more disturbingly than this diagnosis. What's ahead? Well, don't know. Of course, the neurologist can't tell me what progression to expect, and because the disease is so very individualistic, don't really know what path it will take for me. We all know what the end of it is. The end of it is it's going to kill me. But what's it going to do to me between now and then? Don't know. I have to understand that the potential of it could be extremely ugly. I don't know.
You live at home with your wife, and hope to continue as long as you can being independent, right?
Absolutely. Yes, ma'am.
So Ron, for the news crew that just arrived, Susan asked you previously, you had a chance to be in the lab for this study to kind of see what that setting is like. Talk to us again about your perspective of what the lab setting was like.
Okay.
And what this kind of research means to someone who's gotten the diagnosis.
Okay. As far as the lab setting, it very much is a realistic home setting. I mean, there's a fully equipped kitchen there. There's a bedroom, bathroom. It's set up very much like a real living environment. And with that in mind, I think it will be extremely helpful because it will have that element of realism. You're not just off in some corner mimicking something, you're actually doing it. And then in regard to what could it mean for me or someone else, well, even as well as I'm doing now, there are certain things that I don't do as well as I used to. And to be able to have, and this being the first that I know of, and I think it probably is the first of its kind, to try to help us with the disease be able to maintain some independence and some motor and occupational skills for a longer period of time, well, it's tremendous. Because the longer I can do something without somebody having to help me or my wife having to put me somewhere where somebody has to watch over me all the time, obviously it's much better for me to be at home or someone else to be at home. It's also a lot less expensive. And that becomes part of the reality of all of this too, is the expense involved.
Can I ask a question? Sure. Okay. I'll come back here so you don't look to the side. When you got the diagnosis 4 years ago, what was that like? What was the hardest part about it?
From a personal standpoint, the hardest part about it was not knowing a whole lot about the disease. I knew what Alzheimer's in general was. And to all of a sudden, I was 55 years old, to be told that basically you're going to lose your mind. Well, now, that's something I might have been willing to accept at 85 or 90, but at 55, said, and particularly the younger onset, at least this is what was being told 4.5 years ago. Younger onset at that time was typically considered to be a faster progressing form of the disease, and the estimates of life expectancy after diagnosis was between 2 and 7 years. So here I am, 55 years old, with a diagnosis that tells me if you're real lucky, you're going to live 7 more years. And oh, by the way, before you get there, you're not going to have much of any mental capacity left before you get there. That's extremely devastating. You know.
Was it the independence?
No, not so much. It was more, yes. And, you know, you have to look at, are my grandchildren going to remember me? The likelihood of seeing any of them graduated from high school doesn't exist. So those memories and events that I got to share with my daughters and my parents as they watched their grandchildren and then great-grandchildren be born and live through, no. Unless something miraculous happens, I'll never know a great-grandchild. And like I said, probably won't ever know my grandchildren graduating from high school because my oldest one is 12 years old now.
This makes you feel just very helpless.
Well, yes, it does, because it's not a matter of, well, if I, like with cancer, and cancer, of course, is just a terrible disease. I've lost 2 family members, close family members, my father and my sister, to it. And so I don't minimize it at all. But if you're told you got cancer, then they're going to say, okay, we're going to put you on this treatment, and we're going to start doing this, and we're going to start doing that, and we're going to start doing something else. And the likelihood of it being cured is there. The likelihood of them extending your life is most definitely there. With this disease, when you're told that you've got it, they're going to say, well, we're going to start you on this medication. Hopefully, it will help with the symptoms. It isn't going to help with the disease. It's not going to slow it down. It's not going to stop it. It may help slow the symptoms down. In other words, at some point, they're going to catch up with you. So, I'm sure this isn't an accurate statement, but for the most part, most diseases, if they tell you you've got that, there is something they're going to do to either stop it, prevent it, or slow it down. And in this, there's nothing.
Is that why you're happy to participate in the trial?
Well, I well may be a part of it. I don't know for certain at this time, but I'll say this. I try to work with anything and everything I can to help educate the public, to help make mine and my family's life better for as long as I can. And so whatever that may mean. And I don't know sometimes from day to day what that means. We just got to live it out and see. But
Dr. Sarah, can you explain, one of the things that's interesting to me is there are different types of memory. And memory, those different types of memory are impacted differently by the disease. So you're targeting an area, correct, that seems to be a little more hardwired and a little stronger. Can you talk about that a little bit?
Sure. I think any of us that have had any contact with people with dementia know that there are things that people with dementia don't remember. They have a difficulty to remember dates and sometimes faces of the people that they love, times and events. We consider that to be declarative memory. Okay, so that's just a type of memory for those types of things. But we also have a type of memory which is called procedural memory, which is just the memory for how we do things. You all use your procedural memory every day to get up, dress, shower. You don't have to think about it. You don't have to sequence it. You don't have to in any way give any extra mental effort to going through those daily tasks because it's so hardwired from repeating it over and over and over again. So what happens in dementia, or within people with dementia is that over time you start to lose certain skills. And some of those skills have a procedural memory element to them, like bathing, dressing. And so sometimes people lose those skills simply because there's not time for family members to allow them to go through those tasks on a daily basis, or out of love they do them for them. So for example, they don't let mom cook anymore because she might mess up the recipe or she might burn her hand. And so we start kind of gradually taking some of those things away, and then so that memory starts to be lost. But there is some evidence that we can regain that procedural memory, but through practice and repetition, which is kind of the basis for why we've put the study together the way we have.
So recap for us again how the study will work.
Okay.
If an individual qualifies, you will put them in settings where they will utilize this procedural memory?
So basically what they're going to do is identify 3 goals that are very meaningful and powerful for the family. So we are not going to choose the things that they practice. They will choose, which is really unique in research. Usually we tell them what they're going to practice. And so we're giving them the opportunity to tell us, what do you need to be able to do better on a day-to-day basis? Then we're going to bring them to the lab. Or actually, we're going to see them in their home environment first. We're going to see them perform that, whatever that goal is, at home, see where the breakdown occurs. Then, in the laboratory, we're going to introduce strategies, introduce technologies, and through practice of that task, see if we can really rekindle the fire, let's say, in the brain, make new connections from one area of the brain to the other that may not have been connecting before in order to see if we can enhance that procedural memory.
Can you give some examples of the types of tasks that may be practiced?
Sure. It can be anything from basic skills like being able to dress, being able to shave, being able to eat, getting on and off a toilet, getting in and out of a bathtub, to more advanced tasks like being able to balance your checkbook, being able to separate your pills into an organizer, being able to use your cell phone, whatever it is a person identifies to us as being meaningful. And if it's something that we can construct in a way to repeat it, then we're going to do that task.
Why are you so passionate about this?
Well, first of all, I've been a clinician for a long time, and I've seen in the clinic where we're not addressing this well enough. Second, I've had a grandmother that's had this type of condition. And, listening to Ron really brings back for me the feelings that we had when we saw her slowly losing skills that were so important to her. And third, I'm an occupational therapist. I'm trained to think about how do we keep people as independent for as long as we can, despite whatever disorder or disease process they're facing. So it's a combination of things, I would say.
And also for family members, it must be common for them to feel helpless as well.
Absolutely. And part of this intervention is about training family members to use this intervention in their home environment. So they really have the ability to take the intervention beyond the 3 goals that we identify so that they can actually practice it in a way that they can take this wherever they want to go with it.
Will you tell again how you can find out more about the study?
So we have a website that's attached to the College of Allied Health. And then, of course, they can contact me directly. I'm going to be actually interviewing people to talk to them about their eligibility, so they can either email me or call me personally.
You're looking to get started in about July?
The actual the trial is in July, but we need to get people signed up now so that we determine who's eligible and who's not. So we're actually doing that process of the trial. We determine who's going to participate right now. So I'm happy to talk to people at any time.
How many people do you want?
We need 10 people. And that's enough for us to determine, is this type of intervention going to work? About 6 months from now, we hope to have a larger trial of about 20, but we have to do this smaller one first to see if we've got something we can hang our hat on.
Does it need to be early onset? Does it make it early? What age group?
Okay, it's actually 55 to 85, and it's it's mild to moderate. So, and it's actually any type of dementia as well. So it can be Alzheimer's disease, it can be Lewy body, it can be vascular dementia. So we're not excluding based on type of dementia. It could be any type of dementia.
Does he have procedural or does he have the other one that you mentioned?
Well, I'm going to guess if we were to ask Ron, he would probably say he has trouble remembering some things that might happen on like remembering he does such a good job structuring his life with his phone that I think he remembers his appointments pretty well. But I think,
real quick, just
sure,
kind of describe in
sure,
layman's terms. Thank you so much.
sure.
Sorry we got in late.
Yes. Yes, ma'am.
Yeah, just asking you, what kind of things did you start to notice slipping away first? Was it just dates and things, like you said, declarative, or was it routine, procedural?
Kind of a little bit of both, really. And minor things, understand, very, very minor things. Now, I worked a year longer after I was diagnosed, but in that year, I started forgetting. I was a chaplain with the Department of Corrections. I would start forgetting when I'd see somebody, and I'd say, okay, well, come back and see me in 2 or 3 days, and we'll talk about that again, or we'll see how things are going. When they'd come back, I'd have to go, now, what are you here to see me for? Not a real good thing for a chaplain to be asking. But I started those type things. And then memory, most of the time, for quite some time, the dates weren't much of a problem. Anymore, for the last couple of years, my wife has pretty much kept my schedule, so I make sure and stay on it. Now, due to a smartphone, I'm able to start doing that most of the time by myself. This is very much what the doctor is saying she's going to trying to teach people, is how to maintain that independence. And then there's just very simple things around the house that sometimes I do most of the clothes washing since I'm home. I'm forever picking up a load of clothes out of a basket, putting it in the washer, washing it, only to come back and find out I left a piece laying in the basket. Where procedurally, you normally pick up everything, throw it in there, and then you look back in the basket. Okay, everything's there, now go on. I'm dropping out that last step of it from time to time. So it's very minor things, really, but it's very much disease-related because I used to be very detailed. I wouldn't have dropped off things like that.
I know it must bother you.
Oh, absolutely, because, well, for 2 reasons. One, because you just didn't do it right. And when you're accustomed to trying to do things right, you want to do them right. But then secondly, you know that it's not you. You know that it's the disease that's causing it. And so that means you've lost a little more.
You can't do anything.
Well, you start off at the top of the mountain and you're sliding down. And each one of those things tell you you've slid a little further. Now, some days you can inch back up, but you don't ever get back up to the top. And it's a matter of continually slipping down. And every indicator you get of that is frustrating, very frustrating.
Painful for it, I can tell you.
Oh, yes.
Man,
It's difficult. It's hard because we know as you age, things change, and you can't do what you used to could do. But some of these things are not that type of age-related, I can't do that anymore. It would be real ridiculous for me in perfect health to decide I wanted to be a brain surgeon. I don't have the physical skills to do that anymore. I may have the mental skills, but not the physical, even if I didn't have the disease. But these type things with the disease that take away, they just chip away little by little by little. Most of the time, it's not big chunks that erode away. It starts out being little things, and each time you see something, it just reminds you that's just part of the whole, and eventually it's going to be a big whole.
Well, what you described is pretty common for most people in this room. They're like, I forgot when they came in, I forgot a sock in the laundry basket. So I think
But you forgot it because your attention was somewhere else, not because there was a disease eating away at your brain. You just weren't focused.
Do you have a sense of humor about it, though?
Oh, you've got to have a sense. Most of the time I do. Now, it took a while. I've had to come to the place that I realize I can't change the disease. I can't do that. I can change my response to it and how I deal with it. And anything that I do that resists it from a frustration standpoint causes stress, which augments the disease. So it's a lot easier to say, well, hon, don't plan on wearing that pair of socks because I only washed one of them. You know?
Or if she said, when's your anniversary? And you're like, I got dementia.
Yeah. See, I can milk a lot of things like that. Yeah, I can do that. And the problem is she knows when I'm doing it too. So, yes, I go, huh? So, huh doesn't get it too much of the time. So, yeah, yes, you've got to, well, here's the thing. Most of my life, and I think that's common with people, is we work so hard today for a plan for the future. This is a piece of what I'm building for the future. I'd no longer do that because I don't have a future, not to build toward. I better live today, and I better enjoy today. Now, the disease isn't going to kill me tomorrow, okay? I recognize that. But I have to realize that my dreams of, well, when I get to be 65 years old, I'm going to be doing this, and I'm going to be doing that and something else. And so now I got to get all the pieces of the puzzle together today so I can do that then. That's out the window. That's gone. At 55, that ended. That whole plan ended. But I did have to change my mindset to the point that now, okay, what's before me today? What can I do to enjoy today? And yes, you still, you got to remember there's tomorrow and there's next week and things like that. But as far as working diligently today to build for the future, no.
Doctor, could I change the subject?
Sure.
This is not the only thing OU is doing research-wise with Alzheimer's or dementia, is that right?
No, I am working with physicians who are also working on pharmacy-related types of interventions. We also have psychologists who work on caregiver support type of interventions. So we really are trying to build a core of people on campus that have this interest. And even though we kind of are in related areas, we are building a core of people that have this global research interest.
Why is it critical? I mean, can you talk numbers a little bit? Alzheimer's affects a lot of people. It's going to affect a lot more people.
Randall's probably the best one to talk about numbers. He's probably got him on the tip of his tongue. Randall, come on up here and talk numbers. I know we're talking double and triple by 2025, but you probably know the specifics better than I do.
Randall, will you introduce yourself for the
Sure.
online audience also?
Sure. And I'm really not a part, but I will. I'm Randall Lee. I'm Regional Director of the Alzheimer's Oklahoma City office, part of the Oklahoma-Arkansas chapter. And numbers, we've got 75,000 in the state of Oklahoma. We're looking by 2050 to have over 200,000 within the state. 2025, if we don't have a lot done with research, and that's why we're so excited about this happening at OU, because OU is doing quite a bit of research in Alzheimer's and dementia that will affect, we think, in a positive way, the effects of the disease and the helping of the caregivers. But by 2025, it will have doubled. 2050, we're looking at even triple the numbers here in Oklahoma from that standpoint.
Is
So.
that for all dementia or just Alzheimer's?
Well, Alzheimer's is a form of the dementia. We kind of throw them all together. Actually, our name is the Alzheimer's and Related Dementias Association. We just don't say it that way. But it's 60 to 70%, as I think if you noticed in the numbers, about 60 to 70% of the dementia cases are Alzheimer's related.
So at some point, everyone's going to know someone who's had dementia or Alzheimer's or is struggling with that. And as Ron said, this is a disease that takes many years and quite a toll on families.
In fact, what we're starting to see now that roughly 25% of the caregivers are dying before the actual patient passes away because of the stress, the 24/7, the 365 care. And that's why it's so important to have the support groups in place and to teach the individuals how to remain as independent as long as possible.
You probably hear that a lot, that the need, the goal to remain independent is very strong in people.
And I would hope that stays the same. That's the way I want to be. That's the way my dad wanted to be, who passed away with Alzheimer's. the way my mom wanted him to be as well. So yeah, I think that was the number one thing you want to hear from families, or that you will hear.
Why the doubling and tripling? Is it just hereditary? Is it population?
It's the fact that, as Ron said, there's no way to slow it down. There's no cure. There's no way to prevent it. I think what's happening is we're finding ways to maybe note the markers in the genes and the things like that. But until we have the dollars that are available for purity research to find a way to cure it, there's just no way to stop it. And it's really becoming epidemic. And I think part of the issue, too, Ron is very modest. Ron is one of 10 people in the country that serves on a younger onset advisory board. So he travels around the country meeting with other younger onset individuals. And he's, like I said, one of 10. So we're very proud of what he does for us in spreading the word. But as we're starting to see the diagnosis ratchet down, Pat Summit, you're starting to see the Pat Summits of the world, where really the diagnosis is hitting home. And some of those people are choosing to stand forward like Ron does. And in history, the stigma of Alzheimer's and dementia, people stepped back and away. And now what we're starting to see is they're stepping forward. And so that also enhances the numbers or increases the numbers.
So Ron, in your own way, you really are fighting back. You're fighting back for people who come behind you to have a cure, to have a solution.
Oh, yes, ma'am. Kind of a twofold thing, to educate. As Randall said, the stigma that the disease has carried for so long has really hampered research. It's hampered general knowledge because, like, even when I was diagnosed, all I had was an image of an old man sitting in a rocking chair drooling on himself. I thought that was Alzheimer's. I didn't know what to expect. I didn't know what was coming. So, yes, I speak out to help educate everybody while I'm educating myself. But also, now, mine does not have a genetic factor to it. We don't have a history of Alzheimer's in my family. But I can guarantee you, if you talk to my two daughters, they're wondering, will I get it since Daddy got it? And so by trying to get information out there which raises awareness, which raises the push for research and things like that, hopefully my daughters aren't going to have to worry about it, and those that even maybe have a genetic tendency toward it, maybe they're going to find help so that, help for me as far as research goes, in pharmaceutical research and all, let's face it, it just takes too long for it to get through the channels before I'd be able to get it. It's not going to be there for me. I realize that. But it doesn't mean it won't be for my children and children of people with the disease now. So we've got to keep pushing. There is hope. And if we don't speak up, then it stays back in a corner and nobody knows and nobody does anything about it.
But Ron, this kind of research, does it not give hope to people who maybe don't have a hope of a pharmaceutical, but maybe have a hope of living independently longer because of this?
Absolutely. Absolutely. What's happened so much of the time, and I've seen it within our support group, forgetting the sock in the laundry basket. That can just devastate you to the point that you say, I give up. I just quit. I'm so sick and tired of making mistakes. I'm so sick and tired of this disease doing this to me. I'm going to sit here and watch TV. I don't make any mistakes watching TV. Well, you lost. Right there, you lost. So if there is something, and I didn't even think of the possibility of there being something that would help me remember, check the basket twice. I try to force myself as I see things I'm not doing, I try to force myself next time, check it twice, do this, do that. I kind of self-monitor myself in a lot of ways. But then, as I said, I also try to be very careful not to let it get me down. Just go, okay, you didn't wash the sock today. Next time you wash clothes, you'll wash it then. And if I don't pair it up, maybe Vicki will. But this type, what we're talking about here, this type of occupational type therapy in this research, particularly for people who don't self-monitor themselves very well, or people who let it get to them and frustrate them an inordinate amount, this is liable to give them a whole new lease on being, wait a minute, I'm not losing. Or if I am losing, I can fight back to some extent. And to be able to retain any degree of independence is just pretty much immeasurable.